Okay, so again, today I decide to jump the sequence and give you this topic because it's more enjoyable until I go back to the monitoring of the systems. Okay, so today we'll be talking about how you guys can assist in the care of a sick baby. So when the baby crashed in the hospital, what a nurse should do. Okay, so when we look at the baby, and when we take care as a team of any baby, the work should be organized and in a sequence of events. This sequence of events compose of three parts. These parts are evaluate, identify, and then intervene. And then evaluate, identify, and intervene. These three pillars, these three parts, it should be within a block of time. Usually the block of time is 1 to 2 minutes. So we identify, we evaluate, we identify, and then we intervene, and so on. So the first evaluation called initial impression. And the initial impression is you ask three questions. Is the child conscious? You mean responsive or unresponsive? Is the child breathing? And what are the type of breathing? And what are the color? So once you decide if he is unresponsive, then you go directly to CPR. CPR, we usually before we call it ABC, airway, breathing, circulation. But now we change to CAP, which we start with cardiovascular, then airway, then breathing. So we continue the CPR, and then we will learn how to do the CPR later on until the child regain consciousness or regain of spontaneous conscience. Once we regain, we go to the same cycle. Now, if the child is unresponsive, however, he has heart rate, and the heart rate is, so once there is heart rate, you open the airway, you give oxygen, and then you assess the heart rate again. If the heart rate less than 60, you do as if there is cardiac arrest. But if it's more than 60, you go to the cycle of evaluate, identify, intervene. So initial impression, second evaluation called primary assessment, third evaluation called secondary assessment, and fourth evaluation called diagnostic test. So again, initial impression, evaluate, action, identify and action, then evaluate, primary assessment, then identify, then intervention, then secondary assessment as evaluation, then identify, then intervene, and then the fourth one, which is diagnostic testing. This is just a review of whenever the child is crashed, what we should do. Any question on this slide? Do you guys want me to repeat? So it's a block of time composed of three parts: evaluate, identify, intervene. The first evaluation called initial impression. The second evaluation called primary assessment. The third evaluation called secondary assessment. The fifth or fourth evaluation called diagnostic test. After each evaluation, we identify problems. Then we intervene, then we do another. So the evaluation of the primary assessment, we do A, B, C, D, E, F. Airway, breathing, circulation, disability, exposure, and fluid. We do respiratory, cardiovascular, and neurology. There is a question? Question? Mustafa. Okay, Mustafa, mute yourself, please. You're talking. Okay. So after initial evaluation, we go to the primary assessment. And the primary assessment include A, B, C, D, E, F. And so airway, breathing, circulation, disability, which means the CNS, Exposure mean the temperature, the clothing, the chemicals, whatever there, and then fluid. Then we have secondary assessment, and we do something called ample, or some people call it sample. S for sign and symptom, A for allergy, M for medication, P for I just forget the abbreviation. What? I will check it later. And then we have the diagnostic testing. So sample, allergy, medication, previous history, exposure, and L is what? Forget the L for what. Anyhow, we do focus history and examination in the secondary assessment, and then we order tests which include laboratory, radiology, and other advanced testing. Okay? Then after we evaluate, identify problem. So we identify either respiratory or cardiovascular. The respiratory is either upper airway or lower airway, or lung tissue, or disorder of controlled breathing. So then we identify either we have a respiratory distress or respiratory failure, and then we will learn what is that before. And for cardiovascular, we identify also problems. Can be hypovolemic shock, can be distributive shock, can be cardiogenic shock, can be obstructive shock. And then we decide two things. Either it's a compensated shock or non-compensated shock. And then we might identify cardiopulmonary failure and cardiac arrest. Now, these problems can be combined, and sometimes one can lead to another. So we identify initial assessment, primary assessment, secondary assessment, and testing. Then we identified in the previous, now we intervene. So respiratory, we provide positioning, we provide oxygenation, we provide support ventilation, we provide nebulizer and oxygen. For cardiovascular, we provide CPR, we put cardiac monitor, we put site monitor, we put an IV, and so on. At the same time, we activate emergency, and if there is no emergency code in our hospital, we call for help. Okay? So remember, evaluate, identify, intervene until the child is stable. Each of these three should be, each block of time of these three should be 1 to 2 minutes. Okay? We keep, repeat, evaluate, identify until each time we finish and after each intervention. And also we do it when the child condition change, improve, or deteriorate. Okay? So sample, last menstrual, L for last menstrual period. So the first initial evaluation was, is the child conscious? Is he breathing? And what's the color? Primary evaluation, which is the second evaluation, is A, B, C, D, E, F. Secondary evaluation is sample, sign and symptom, allergy, medication, past medical history, last meal, and event. Okay, and also we do focus physical exam, primary area of concern, and then we do head to toe. Now, this is not your job. Until here is not your job, but I will show you what exactly we are doing and what is the nurse should do. Okay, the diagnostic test that we order in the child is sick is arterial blood gas, venous blood gas, capillary blood gas, hemoglobin. We do central oxygen monitoring. We do arterial lactate. We monitor the central venous pressure. We do invasive arterial pressure, chest X-ray, ECG, echo, pulmonary function test, and so on. Okay? So again, when we have a sick child, we do a block of time, evaluate, identify, intervene. Each block of time is 1 to 2 minutes. A first evaluation called initial impression. Second evaluation called primary assessment. Third evaluation called secondary assessment. Fourth evaluation called diagnostic testing. Each one, then we identify problems, and then we intervene. For a nurse, for a child, whether the child is sick coming from either hospital or crash, we should do a checklist. This checklist includes the following. The nurse should be responsible that each and every one of the team should introduce themselves. And we should assign a leader. And then the leader or somebody from the team should brief the rest of the coming problem, whether it's coming from another hospital or it's crashing in our hospital. We need estimated weight. If we have the weight, is great, but if we don't, we can calculate the weight based on the age. We should ensure that there is oxygen source, whether from the wall or through the bottle. We should also have air source, whether from the wall or a ventilator with a compressor. We should have air oxygen blender. We will show you that inshallah in the future. We should have ambu bag, self-inflation bag. We should have a flow inflation bag. We should have intubation trolley, and I will tell you later on inshallah what intubation trolley should have. We should have RSI. Have you guys ever seen RSI? Anybody seen RSI?
I haven't seen even, doctor.
Yeah. So I will teach you inshallah in one session what is RSI. It's a rapid sequence intubation. It's a preparation of the child for intubation from medications and from system. The ventilator should be checked, tested on a test lung. The mode should be ordered by the doctor and asked by the nurse. The setting, the PIP, the PEEP, the rate, the inspiratory time, inshallah, will give you all this information. We need a transport ventilator. Inshallah, we are preparing the transport ventilator in the hospital. We need transport system, transport incubator, and transport tray. We need a list of blood tests, presumed blood tests. We need a list from the doctor of presumed radiology order. We need tools to confirm correct placement of the endotracheal tube, which is capnography, that is continuous monitoring on a monitor of the CO2, or end-tidal CO2, which gives us the CO2 one reading in a respiratory cycle at the end of exhalation. We need a stethoscope to check the air entry. We also can check loops and graphics on the ventilator, and I will teach you later what's loops and graphics with time. We need a saturation monitor, whether it's on the wall or it's a portable. We need cardiorespiratory monitor with through probes on the chest. We need a peripheral IV set, and I will show you the checklist of peripheral IV. We need a central line set, and also I will tell you. And we need a resuscitation bag, and then we'll work together on a resuscitation bag. So after this checklist, pre-arrival, you have also a job when the baby arrives. So what is a nurse? The doctor will do initial assessment, initial impression, primary assessment, secondary assessment, diagnostic testing. That's the job of the doctor. The nurse should do the following. The nurse should make sure that the airway is protected. And if the airway is not protected, should be open. And if it's not open, we should use respiratory support. Also, we should protect the spine, especially if there is trauma. The nurse should be able to do Glasgow coma scale. And it's very important to do that before the RSI. Have you guys practiced Glasgow coma scale before?
Yes, I do, sir.
Okay. Also, the nurse should do the primary assessment, which means A, B, C, D, E, F. Airway, breathing, circulation, disability, exposure, and fluid. The nurse should call the doctors and make sure that the doctors are available when the baby arrives. And also, if there is subspecialty like cardiovascular, like cardiology, like pediatric surgery, when the baby is sick, we should have at least 2 nurses. Okay? We should already have the arrival checklist that we talked about it. And we should introduce the staff to each other, and we should introduce the staff to the patient relatives or the patient themselves. Now, it's very important when we care sick baby and the doctor doing their assessment, okay, we should know what is the role of the team leader and the team member. So we'll say, nurse A will take care of the respiration, nurse B will take care of the cardiovascular, and nurse C, for example, will do the IV fluid and the medication and do documentation. Dr. A will do this, Dr. B will do this. So that's very important for team dynamic. And it should be closed loop communication. What does that mean? Closed loop medications. Okay, means that I am Dr. A talking to nurse B. So I say, nurse B, do bagging. The nurse B should say, yes, I am doing the bagging on, for example, 12 breaths per minute. So the message should be clear, loud, and we should get reply. Yes, I know. Yes, I don't know. No, I need help. Don't do anything you don't do. Don't waste time. Either you know or you don't know. And that's what we will practice when we drill, when we practice on a minicans. Either you know or you don't know. If you don't know, we'll practice. If you know and you take tick that you know, then you will be accountable when you cannot do. And if you don't know, our job to teach you. Therefore, the message are very clear and could be closed loop. Closed loop mean I send the message, I get the reply. That is the clear role, what exactly you're doing, okay, and what's your responsibility. Don't do anything you don't know. And if you don't know, ask, I need help. Know your limitation and share your knowledge. If you know something, tell others. Okay, constructive intervention, which mean don't criticize, critique, help. Don't criticize. I can do. You're busy. Don't say to anybody you don't know. No, I can do. You look busy. You look tired. Always reevaluate and always summarize when you've done. Mutual respect. Respect the other team. Respect the team member. Okay. So we did pre-arrival checklist and we do arrival checklist. Okay. Any questions so far? Okay, so if no question, let's go ahead. Now it's very important for the face mask. Now the face mask, we will take it later on, inshallah. There are many types. There are rebreathing, partial rebreathing, non-rebreathing, Venturi. There are many types of face mask. We'll talk about it later. But it's very important when you select the size of the mask is to fit the tip of the chin at the point where the two eyes meet at the nose of the bridge. So it's here. This is the correct. The tip should be where the two inner canthus of the eye meet and the tip of the chin. Okay? You should not, if you don't reach the chin, then there is a problem. If you don't reach between the eye, there is a problem. If you override, you pass the distance between two eyes and reach the eye pro, you have a problem. If you pass the chin, the tip of chin, you have a problem. Okay? It's very important to remember that. Incorrect position, big size. Incorrect position, small size. Correct size. The mask should be circular. We don't use mask with notch. Okay, always use mask with notch. There should be tight seal. So it's better to have a mask with cushion, and the cushion either filled with air or filled with water. And that's why it should be very flexible and soft and should be tight seal. The mask should be transparent so we can see the mouth and the nose. Okay, and there should be indication of exhalation, which means that there is a steam, there is vapor, there is water, there is bukhar inside the mask. That's very important to see. And if not, then that means the child is not breathing. Okay, we should know the ventilation bags. We have two types. We have the self-inflation bag. Self-inflation bag mean when you compress and release, it re-inflate itself. You don't need a flow to inflate it. And it composed of parts. It's the mask, and there is the swivel between the mask, nasal mask, and the position on the machine. There should be a gauge to measure the pressure, and then we have the bag. And the bag, you have three sizes. We have 250, we have 500 and 750. And the mask will be the according. And you can see that it's with a cushion, and it's a circular. There is no rim, there is no notch. And you can see there is a carrier, so you can put your finger on it, inside it. So you can see that there is a reservoir, and you can see there is oxygen connection. Now, it's very important to remember that each finger gives you 15 centimeter water. So if you press between index and thumb, you're giving 15. If you press index, middle, and thumb, so 3 fingers, but don't count the thumb. So there is 2 fingers, then you're giving 30. If you use 3 fingers, you're giving 45. If you use 4 fingers, hold your hand, then you are giving 60. Now, is that clear? Questions? 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 Any question? So then this is the, go ahead, please.
I'm sorry, doctor, but that type of mask is rebreathable mask or non-rebreathable?
The mask, here we will talk
Yes.
about the rebreathable and non-rebreathable. It should be non-rebreathable because we will bag through it. If it's rebreathable or partially rebreathable, it will not bag the baby. So rebreathable and non-rebreathable is only we use it when we deliver oxygen. Okay, we don't use rebreathable or partially rebreathable when we bag. If we need to bag, the mask should be non-rebreathable. Because if it's rebreathable, there will be an opening. And when you compress to inflate the lung, the air will escape from the holes and the baby will not be back. Okay?
Okay, doctor. Thank you so much.
Yeah, you're most welcome. So remember that you have to attach the oxygen saturation. Okay? And if you use flow inflation bag without reservoir, you can give up to from 30 to 80% FiO2. But if you use reservoir, you can reach up to 95. This is the reservoir. You always need to put the safety pop-off valve, okay? Because we attend to compress very strong. And if there is no safety valve, when you give more than 45, like 60, it will go 60 to the lung and cause pneumothorax. So it's always the safety valve should be at 45. It's very important to use appropriate size bag from 250 to 700. Okay, we usually don't use more than 700. It depends on the size. This is wrong. This is 1000. Okay.
Dear doctor, just one question.
Go ahead.
Can we say if there is the safety valve, we can prevent the barotrauma for any age,
No,
for
that
example,
we
for
will not
premature?
cause paratrauma by bagging a baby for a few times. The paratrauma usually happen when we ventilate the baby with pressure control or of pressure control ventilation for a long time. But the problem when you bag, you can cause pneumothorax. But if you bag for a long time, like 3-4 hours continuous, you can do paratrauma. But the safety valve is to prevent any extra pressure, because when you press, you are giving PIP. Because remember, you have PEEP and PIP. So when you get excited, when you get scared, when the patient is dying, you tend to compress more strong, and you don't notice. So it's very important to put the safety valve. That's whenever you give more than 45 centimeter water, it will be released.
Okay, thanks.
And also you can connect to pressure manometer, which tell you how much you are giving pressure. Always check device. Always put the baby in a sniffing position. Do you guys know what sniffing position? Anybody knows what a sniffing position is? No. So is the tip of the nose and the tip of the chin on the same level? The tip of the nose and the tip of the chin is on the same level. So if you put a ruler or a paper, it will be straight, it will be transverse, it will be the same. That's what we call it sniffing position. And in that position, the upper airway will be open because everything will be aligned, like on the same level. Now, is that clear? Sniffing
Is it
position. The tip of the
isn't
nose and the
head,
tip of the
head
chin on
till
the same
chin
level.
lift or the other position?
Sorry?
I mean, I said head till chin lift. It will be the same position
No,
or
that's a different. These are no the head tilt and then these are maneuver. But the purpose of the head tilt, chin lift is to put the baby in a sniffing position. That's the purpose. Okay?
okay, dear.
But
Uh,
head tilt,
Doctor,
chin lift
sorry,
is a maneuver. This is a position. Go ahead.
I'm sorry, doctor, but why the baby must be in sniffing position?
Because when you put
About
the
what?
baby in a sniffing position, you open the upper airway. All the upper airway, the mouth, the nose, the larynx, and the trachea will be on the same line, will be on alignment. They align together. They become in as if they are one tube. When you put
How,
the
doctor? You mean during intubation? Sorry.
always the child position should be in a sniffing position. Always somebody should, because when there is one person will take care of the breathing, right? So
Yes,
that the
of
same
course.
person will hold the baby. Okay, and that they will do head tilt, chin lift, they put rolls under the shoulder, under the head. So that person who's taking care of the breathing and the airway should always hold the baby in a sniffing position. But if we put the baby we put endotracheal tube, there is no need for sniffing position anymore because the tube now control the
Yes,
breathing. But sniffing position is needed before inserting the endotracheal tube.
yes, doctor. I remember this. Thank you so much.
Okay, we will practice that. Don't worry. I'm just introducing it. Okay, then we have a flow inflation bag, and this is also called anesthesia bag. The problem with this bag, sometimes there is valve here, sometimes there is no valve. Okay, there is a valve. The valve also some people make it open and they hold this valve by their fingers and they release and close this valve by their hand so they can control the inflation of the bag because the inflation of the bag depending on the flow that's coming through this tube. And we have different sizes. The problem with this bag, they will never inflate whether without flow, there should be a flow, oxygen or both air and oxygen, and there should be tight seal on the face. So it's very important to remember the anesthesia bag will not ventilate. We cannot bag a baby without having a tight seal and we have a flow to inflate the bag. That's what we call it. So the good news about this bag, it can give 100% oxygen. Also, when the baby is not ventilated, we will know because the bag will not be inflated. If the valve is not inflating, then either there is a safety valve open, or there is crack in the bag, or there is no tight seal, or there is no flow. So whenever any of these are not working, so it's usually need only we can use it at the bedside or during the surgery because it's need air source and oxygen source. While the self-inflated bag we can use it anywhere, even on the street, because we don't need a flow to reopen. Okay, so that's the difference between the flow inflation bag and self-inflation bag. The flow inflation bag can give 100% oxygen. It will never inflate without flow. It will never inflate if there is a crack. It will never inflate if there is no tight seal. While the self-inflation bag, it will inflate. Even if there is a crack, it will be reinflated. It will reinflate even without bag, or it reinflate with even the... So this is the sniffing position. Anybody ask me about the sniffing? You can see the tip of the nose and the tip of the chin on the same level. So let me show you. Let me insert a shape. Do you see? Okay, if you see, let's see this one. Do you see the correct position and do you see it? Answer me, please, because I want to teach you.
I get it, doctor. Yes.
Yeah. So this is a sniffing position where all the airway will be open. This is hyperflexion. This is hyperextension. Okay. Now, when we hold the bag, it should be C and E. C and E. E is by our little ring and middle finger. Little ring and middle finger. That's an E. And then we have C between the index and thumb. The C, hold the bag, hold the mask. The E, pull the jaw. So when you press by this two fingers, you press on these three fingers. You don't press on the baby. So you pull by one hand and then you push by the two fingers. Okay? So that's what we call it C and E hold. So you pull and push, pull and push. The pull and push is not on the baby, it's on your hand. And that's why it's very tiring. Now, if your hand is small or if you don't strong, you need two person. And sometimes you need two person. One is holding and one is bagging. Okay? And the reason, because here you need one hand and the other hand will be bagging. You can see. So if you're not able to do it, then you need another person. One is holding and one is bagging. But it's very important not to push on the baby, because once you push on the baby, you will not bag. Now, is that clear?
Yes.
Yes.
Okay. Now, when you give the breath, watch the chest rise. Remember, you need tight seal. If you're not able to breathe the baby, then you either have an obstruction, mucus plug, secretion, or the lung compliance change, or you have pneumothorax, or you have a bleeding. Okay, there is something. Now, please avoid fast breathing. You don't need to breathe the baby very fast because you will wash CO2, and once you wash CO2, you'll interfere with the flow to the brain. So you don't need to breathe the baby. You need to go on a sequence, and we'll teach you how to do that. Okay. Now, what is the parameters that the baby is breathing? Well, good chest rise, saturation more than 94, heart rate is okay, exhale CO2, so there is CO2 with our bicalorimeter or capnography or end-tidal CO2. Blood pressure is stable. There is good air entry at the axilla. And the color, the baby is okay, appearance is all, baby is not agitated. If not improve, then reposition the baby. You might need to put shoulder roll. You might need to do head tilt, chin lift. Okay? You might need to change the mask. Do you guys know Mr. Soba?
No.
Mr. Soba is an abbreviation that we use how to correct when the baby is, okay? So mouth, reposition, C, suction, O is obstruction, B is positive pressure, and A is adjunct airway. So Mr. SOBA is an abbreviation, or it's an acronym that we use to remember if the child is not improving. Mr. SOBA, we will learn it later, inshallah. So Mr. SOBA is helping you to remember if the baby is not opening. Okay, so remember, you need reposition, you might need to do head tilt, chin lift, you might change the mask, you will look at your seal, you might need to suction, you might need to check your oxygen source, you might need to check your bag and your mask, you might need to deflate the stomach, you might need to avoid giving pressure more than 45. Okay, now you might need to give longer breath, you might need to slow down to give the breath, you might need to do cricoid pressure to prevent flowing from the lung. You might need orogastric tube or nasogastric tube. Okay, now it's very important when we intubate, we need an intubation list. Okay, so these are very important to remember, that you need a flow inflation bag, you need self-inflation bag, you need ETT, you need a stethoscope, you need a scissor, a tape, a laryngoscope, a different size of ETT, a T-piece, or that's what you call it, neopuff, that can give you pressure with the flow inflation. It's a portable machine. LMA or laryngeal mask airway. I will teach you that, inshallah. Okay, and saturation monitor and so on. So it's very important to have a checklist for ETT. Okay, so when the baby is intubated, you need intubation when you cannot maintain open airway, when you need oxygenation and cannot give it by bag, when you need to ventilate. And when we say ventilate, we mean the CO2 level. So you always need pre-intubation checklist. We will provide you this checklist. So you need a universal precaution, okay, when you intubate the baby, especially you guys remember Corona or COVID-19. But in PICU, we don't have only Corona. All the viruses can cause infection to us. So you need a gloves, you need a mask, you need to protect your eye by putting a face shield. You need a cardiac monitor on the chest, 3 probes. You need a pulse monitor on the right side. You need a blood pressure monitor, invasive or non-invasive. Put the cuff and set the monitor to measure the pressure every 15 minutes, for example. You need end-dial CO2, or you need exhalation CO2, capnography, or even colorimeter that change the color when the baby is breathing between red and yellow. I will show you that. You need IV set. You need, if you don't have IV, you need intraosseous, okay, because you need the medication. You need oxygen. You need mask with appropriate size. You need oral and tracheal suction with appropriate suction tube. You need appropriate pressure for suction. You might need oral or pharyngeal, nasopharyngeal airway. You need ET tube for different size according to the size of the baby. I will show you that. And one and size above and one size below by 0.5. You need laryngoscope and 2 blades, straight and curved if the baby is more than 8 years. You need sometime video laryngoscope. You always have to have 2 laryngoscopes and 2 batteries. Okay, you need the cuff pressure monitor when you use cuff tube. What is the pressure in the cuff? You need syringes, 3 ml, 5, 10 ml. You also need adhesive to fix the ETT. And it's better to have a commercial ETT holder, such as Neobar. Fix on the check, put the handle in between, fix the ETT on it, and that will be good because the tube will be in the middle, not when you fix the tube by a piece of gauze or towel, the tube will go to one side. You need towels to cover the baby and clean any secretion. You need pads or pillows to align the airway of the baby, okay? And you need tools if you have difficult airway and difficult intubation. You need to learn how to put intraosseous if you cannot put a quickly peripheral IV, especially in a shock patient. Okay, this is the color-coded length-based resuscitation. Each nurse should have high, and I will print you one and show you, because this will give you the measurement of each and every equipment according to the weight, and it's color-coded. Okay, so it's equipment, resuscitation bag according to the weight, oxygen mask according to the weight, oral airway according to the weight, laryngoscope blade according to the weight, but this is not including newborn, by the way. ETT size according to the weight, ETT tube insertion length according to the weight, suction catheter size, blood pressure cuff, IV catheter size, intraosseous size, feeding tube size, urinary catheter size, and chest tube size. Now, is that clear? Guys, talk to me, please, because if you don't talk, I don't know if I'm teaching you or not.
Is it clear, Judge?
Great. Please talk to me, huh? So what do we do then after we resuscitate a baby? We need a post-resuscitation list. So remember, pre-arrival list, arrival list. We talked about the airway and respiratory sources, very important. And then after arrival or after resuscitation checklist. And these are, we need to maintain the oxygenation. Okay, so we need to make sure that the saturation is always above 94. We need to make sure that blood gas was done. And we need to know if the baby after resuscitation will need CPAP. So the CPAP have to be ready. And if we decide to use high flow nasal cannula, should be ready. The bed and the PICU and NICU should be ready. Ventilator at the bed should be ready. Mode of the ventilation should be selected. The setting, the PIP, the PEEP, the rate, the inspiratory time should be decided. Chest X-ray, informed and ready, portable to be taken. Portable lung ultrasound should be ready. Okay? We should always check the CO2 level, whether invasive or non-invasive, by blood gas or by monitor. Avoid rapid correction in asthma, rapid correction of CO2 in asthma and respiratory failure. Please, when you check, avoid pneumothorax. Continue checking CO2 by capnography or intermittent calorimeter. Always verify the position of the ETT by the X-ray or ultrasound, and the doctor should sign where is the tip of the ETT. Always check the CO2 to be between 35 to 45, unless we do permissive hypercarbia or hypocarbia. So the doctors say, I'm okay if the CO2 more than 50. They should be signed. Otherwise, the CO2 should be at 55 and 45. The chest should be always rising. Gas, ABG or CBG should be ordered. Okay, during resuscitation and after the baby regains spontaneous consciousness. We can do the gas every 15 to 1 hour. It depends on the question. ETT pressure should be inflated and checked by manometer and should be somewhere between 20 to 25 centimeter water. Pain should be controlled by morphine, fentanyl, paracetamol, non-steroidal. Sedation should be given midazolam, lorazepam, phenobarbital. Neuromuscular blockade sometimes used like rocuronium or succinylcholine. Ventilatory setting should be, and the usual setting that we start is assisted control volume guarantee, ACVG. Or sometimes we use pressure support ventilation plus VG. Or sometimes we just use assisted control without VG, depending on the situation. Saturation monitor should be always checked. Tidal volume, always checked between 3.5 to 8 ml per kg per baby. Inspiratory time between 0.5 to 1 in pediatric patient. In a newborn, between 0.35 to 4. PIP should be between 20 to 30 centimeter water. Rate, 20 to 60. Okay, if in children, maybe 16 to 20. An adolescent, even lower. DOP, you always check for DOP. DOP means displacement of the ETT, obstruction of the ETT, pneumothorax, and equipment failure. Remember DOP when the baby is desaturating. Post-resuscitation cardiovascular should be checked, the heart rate, the blood pressure, the saturation, central venous pressure on the infusion pump, echo, whether we required or not. Check the central line, check the capillary refill, check the extremity temperature, check the heart rate, change organ perfusion, such as bowel sounds, such as urine output, such as capillary refill, such as renal function test. Always check the ABG or CBG or VBG. Check hemoglobin and hematocrit, glucose and electrolyte and renal function, lactate, X-ray, ECG, echo. Remember, IV, at least we should have 2 peripheral IV, or at least 1 peripheral, 1 central. Always control pain. Always look at the sedation. Check for arrhythmia. And always check for possible post-arrest myocardial dysfunction. Anticipate. We might need to use vasoactive agent. We'll check all that. Look at the metabolic derangement, potassium, calcium, magnesium, sodium, glucose, lactate, acidosis. Consider the invasive and non-invasive blood pressure monitor. Always when you have shock, you need at least 2 IV access. Remember, if we have a preload problem, we need IV bolus. And remember, we might need a maintenance IV fluid. Contractility has to be checked by the doctor. Maintenance. Okay, after load, we might need to be vasopressor or vasodilator. Medication for shock, epinephrine, dopamine, norepinephrine, dobutamine, epinephrine, milrinone. For neurosurgical, always check the temperature, the heart rate, blood pressure, and tissue saturation by NIRS. We don't have NIRS here, but I think in the future we'll bring it. Glasgow Coma Scale, or AVBU, if you guys know what's AVBU and PIRL. AVBU is, do you guys know?
No, doctor.
arrival يمكن assessment such as classical muscle.
A, agitation, V, verbal response, P, localization for pain, and U, unresponsive. Pural is bilaterally equal reactive, pupil equally reactive to light. Pural. Pupil, sorry, equally reacted to light. Avbu is agitation, V, verbal response, P, pain localization, U, unresponsive. Or we can use the formal Glasgow Coma Scale. We always to look for sign of increased intracranial pressure and sign of herniation and cooning of midbrain and may cause death. Seizure, we might note EEG. We have invasive and non-invasive. Posturing of the baby, you have decorticate and decerebrate. You will learn this all when you work with me. Test always, we need to check the status of the brain by test. We might need CT scan. Renal, we need to measure urine output. Bladder, this is wrong. Spelling mistake. Okay. Abdominal examination, urinary catheter, test also we need to do. We might need to volume and check for fluid, nephrotoxic medication, diuretics. Okay, all this need to be checked. GI, abdominal examination. Okay, liver function test and bilirubin, ammonia level, very important, especially in inborn error and intoxication. Coagulation profile, pancreatic injury, pancreatic enzyme, bowel ischemia, ultrasound, CT scan of the abdomen, gastric distension and feeding tube, ileus and hepatic failure. Transport, so we have pre-arrival checklist, we have arrival checklist and post-resuscitation checklist, and we have transport checklist. Which transport you will do? You are doing by ground or by flight or by sea? I mean, inside hospital, basically it's a ground. Team, we should have a doctor, MD, and nurse registered. And we don't have respiratory therapist RT here, but we can have 2 nurses. We need paramedics, pilot if we are flying, driver if we are using a car, tools that we transport bags, documentation, receiving physician and sending physician, and also receiving and transferring hospital. Okay. A resuscitation drug all needs to be ready, especially the alpristol, which is opening the PDA, imidazole, dopamine, epinephrine, these are the doses. Insulin, isoproterenol, labetalol, lidocaine, procaine. Okay, we need intubation sizes by age. You can see this list. Okay, so with time you will learn all this. And medication, again, epinephrine for anaphylaxis, diphenhydramine, ranitidine, hydrocortisone. And I am done for this session. And let me stop recording.